Welcome to Your Source TV. Be empowered and encouraged to think outside the box. I'm Tamara Stuchlak, and in this segment, we explore the doctor-patient relationships, changes in medical philosophy, and new dynamics in medical business management. With us is Stephen Davison, MD. He's the Clinical Associate Professor at Georgetown University. He's the founder of DAVinci Plastic Surgery. Dr. Davison specializes in reconstructive and plastic surgery. Welcome, Dr. Davison.
Thank you very much for the opportunity to be here.
We'd like to jump in and learn more about your new practice and the unique things that you're doing there.
Well, after spending the last decade at Georgetown University, I've opened a private practice known as DAVinci Plastic Surgery. And the reason I opened that practice is to develop a patient-centric practice, one that goes back to those the fundamentals of the relationship between the patient and the doctor. What I found what was missing in most medical care nowadays was the sort of quarterback of care. And although you may not think of plastic surgery as having to deal with a lot of true patient care because it's been spun differently in the media with television shows, plastic surgery deals with a lot of complex medical problems, reconstructive problems, post-trauma problems, congenital, which are really fundamentally based in the patient-doctor relationship.
And you have a unique reason for naming your new practice DAVinci.
What's important to know about DAVinci is he was an anatomist, he was a scientist, and he was an artist. And the blend of those skills that he had was what made him so important in the Renaissance. And as such, I thought it was an excellent name because those are the same things that really define plastic surgery, anatomy and the art of surgical science, really.
And so you're also indicating that you have a renaissance in this doctor-patient relationship, and you're suggesting that we've maybe overall in the industry gotten off track. How so?
Well, what I found taking care of breast cancer reconstruction patients, head and neck cancer patients, post-bariatric patients, taking care of skin cancer and head and neck reconstruction patients, which is a large part of my practice, I found that the patients were always coming to our practice asking questions and looking for somebody to help coordinate things for them because nowadays, so often there's not enough time to either educate or to get the patient the right services or to get them to the right place, their rehab, their x-rays. It's go and see this one, but no one's coordinating it all. And it was getting more and more difficult for me to do that without taking control.
So once patients leave their primary care physician and are in the surgeon's hands, there's no coordination of care per se?
Well, what I found working within an institution was things worked very well vertically. So vertically, you could see a patient, analyze a patient, take the patient to the operating room, take their bandages off. But the difficulty became whenever you needed something horizontal. If you wanted to get an x-ray or you wanted to send the patient to rehab, it became difficult to do any type of horizontal integration. So I needed to take charge of that for myself.
Is your new practice a different model than straight insurance pay, or?
We're a practice that accepts insurance because we don't want that to be a barrier to access for patients. But I have someone, a patient care coordinator, who will help you work through that process and explain to you, what your responsibilities are, what a copay is, what the deductibles is, but to try and streamline it for you before it ever becomes difficult.
Could you talk a little bit more about your unique perspective and philosophy on the doctor-patient relationship? Because I know that that's something that's very important to you and what you've specialized in your reconstructive care for complex cases.
Well, the most important, I think, the different thing about the patient-doctor relationship is, it's really not different because you hear it all the time, but I think there's a lot of lip service to it, is you do have to listen, right? So I think doctors nowadays are pushed more and more to move things along, to keep the mill moving. But I think what you have to do is you have to listen. And if you're not a good listener, then you need to surround yourself with listeners. So that's one of the things that I try and do is when I'm first talking with a patient, it's what bothers them. What are they here for? Because what you have to do is you have to identify, at least in my field, what the patient wants.
Is this something that you found was not being instilled in the teaching of new medical students, or just didn't translate well in the practical?
I think it's one of those things that's constantly voiced, but seldom modeled. You know, until I have this new model that I currently have where I'm, running my own practice, I rarely had residents rotate with me in the clinical environment. Now I actually have one assigned with me that it's more of a mentorship role, so they see every interaction from beginning to end. And it's a longitudinal experience where I can show that resident or teach that resident, what's involved in the consultation, what's involved in listening to the patient, what's involved in then trying to wean out what they really want, as opposed to, what you think they need.
Is this new to medical training or being further emphasized at Georgetown?
I think there's a number of things that are changing in medical education. I think medical education, it's got a number of new core curriculums in it. Medical education's been separated now into core curriculums, and for instance, they have a core curriculum on professionalism. Now, one would have thought that professionalism was inherent to being a physician, but not necessarily. I mean, I hate to say it, but you sort of have to teach those values nowadays. And then the second new core curriculum is something called systems-based practice, which is how the patient is impacted by all of the other things in the medical care, the hospitals, the insurance, provision of care, all of these other things that really aren't medical, but yet impact on everything that they have in their medical experience.
Back to also your philosophy of there's a missing quarterback in the whole mix of...
And that comes down to the same thing. To be the quarterback of patients' care, one, the quarterback has been dispersed by the insurance company, asking everybody to get referrals and really turning the quarterback into a paper puncher. But it requires a certain ownership of the patient. When the patient comes to you, you need ownership.
And you also have a philosophy on this combined greed and fear in the medical profession.
Well, what that is that's about motivation, right? And the people and this is a totally biased view, is I think are motivated by one of two things. I think people are motivated by fear. Will I get in trouble? Will I have to do more work? Will I be found out? Will I be shown up? That's motivated by fear. Or you can be motivated by greed. Greed, not in a negative sense as in just money, but greed for education, greed for knowledge, greed for new techniques, greed to advance things. That's greed.
Self versus patient.
Well, it doesn't have to be, but just a greedy person, a person who wants to do more interviews, more TV shows, throw, more footballs. It doesn't matter what it is, have more touchdowns.
So how does that impact?
You want to surround yourself by greedy people, right? You don't want to surround yourself by people who are motivated by fear, because fear dulls. Anybody who's motivated by fear, their fear is dulled, and their motivation is dulled. Greedy people, by definition, are insatiable. So they're insatiable for knowledge. They're insatiable to do things, to do more operations, to take care of more people, to provide better service, as well as, be more productive, which is a positive thing. So I surround myself with greedy people.
And some specific examples of how you work with your patients in terms of encouraging psychological support, maybe uniquely so for maybe the viewers listening, in terms of just thinking, maybe in limited ways about reconstructive or plastic surgery and your role.
When I was a resident, there was a moment of epiphany when I worked with a physician in Pittsburgh, and he, at the end of every interaction with patients, he would say, "Do you want me to do nothing? Do you want me to inject this?" He was a hand surgeon. "Do you want me to inject you with steroid, or do you want me to operate?" And I realized, that sounded really like,
Bottom line.
Bottom line. But it was really profound. He had reduced the patient's care into 3 things, and he had made it simple. And so when I became a plastic surgeon, I realized I could add 2 more, one of which I call lotion and massage, which is all manner of vitamin E oil or skincare products or scar management. So that's lotion. So I can do nothing, I can operate, I can inject you with steroids or other agents, lotion and massage, or the last one is I can send you for psychological help, because some of your problems I need help that I can't fix because they're deep-rooted. Say, the sexual connotations of having a mastectomy. You can fix the breast, but can you then deal with the wounds? I can't. I need help. So what I do is then bring in that 5th dimension and send patients for that help. And we keep a stack of behavioral psychologist cards and give them out to anybody that we don't feel that we can help in that dimension, because there's a lot of people in that group.